Okay, so we've been joined by Andrew Tatarsky. Andrew, do you want to introduce yourself?
Sure. I'm a addiction psychologist. I've been working with drug users for 35 years in a number of different capacities. I have written a book called Harm Reduction Psychotherapy, a New Treatment for Drug and Alcohol Problems, essentially elaborating a harm reduction approach to psychotherapy, substance use, counseling. And I strongly believe that a harm reduction philosophy needs to infuse the continuum of care in order to increase our capacity to help people that struggle with drug and alcohol problems. I also founded and direct the Center for Optimal Living in New York City, which is a comprehensive psychotherapy and professional training program that is organized around these integrative harm reduction psychotherapy principles. And the center really functions as a platform for advancing this new narrative about how we can be more helpful to more people when we integrate harm reduction principles into a comprehensive, integrative approach to substance use treatment.
We were talking earlier, and I suppose the fundamental questions are, why do people use substances? And why do people who use substances or other people find some substance use problematic? So what do we mean by that? And how do we drive towards a notion of addiction or addicts, a term neither of us use with any comfort, I suspect, but how do we define the people we're looking at? So what's the problem and who's affected by that problem?
Mm-hmm. Well, I think that our language is really important to look at. The concept of addiction, we might think of both as describing an experience and a set of behaviors related to that experience. And I think that most people can agree on sort of the general characteristics of that addictive experience. We generally think of loss of control. We think of continued use in spite of negative consequences, some notion of craving or compulsion. And I'd like to point out that those are all experiential descriptors which can be reflected in behavior. Yeah. I think a key question is how we understand the nature of that experience and behavior. And the model for understanding makes all the difference. The dominant model that has dominated the globe, certainly, is that this addictive experience is a biologically based disease that has something to do with the interaction between the drug and one's biology. And that has given rise to a certain approach to treatment. There's a whole history of assumption that disease is permanent, chronic, progressive, and only arrested by complete and total abstinence. So that's a certain addiction recovery narrative. It's like a story. Yeah. And that notion of the addictive disease has informed a dominant approach to treatment, which we call abstinence only. That is, the only way to arrest the disease or send it into a remission is through a complete and total abstinence commitment. And so that's the dominant notion. The problem with that is that approach to thinking about addiction and treating addiction has been an abysmal failure. The majority of people who struggle with drugs and alcohol are not ready, willing, or able to embrace abstinence. They don't find abstinence-based treatments really relevant or appealing or effective. And we look over the history of this addiction treatment approach and see an abysmal failure. starting with the fact that most people don't go to those treatments and most people don't get helped by them. So that, in my own experience as a clinician, led me to begin to wonder what's wrong with this picture. And I think that what I've come to is to suggest that the basic model for understanding, that is reducing addiction to this biological basis, and the corresponding treatment approaches are both wrong. The data of how people develop addiction problems, who this complex, diverse group of people is, and how people make positive change in their lives doesn't support that disease model or that abstinence-only approach. It really suggests that we need a whole new, much more complex model that I call a psychobiosocial approach, meaning that we need to be thinking about how biology, psychology, social context, relationship context, the broader political context, and more, all interact in ways that are really unique for each person in giving rise to the impulse to use a drug, to continue to use a drug, and to develop problems with that drug. And that much more complex model suggests a number of different ways that we can much more effectively work with people to develop more comprehensive, more individualized approaches to care that actually really work, that are relevant, that are appealing, and that are effective.
And in terms of...
So let me say one other thing about that. So what I've been thinking about is that this model shift is really on the order of a scientific revolution. We're talking about the need for a whole different scientific paradigm for how we understand this huge population of people that struggle with problematic drug use. And it's a new paradigm, a new model for understanding that then provides a kind of theoretical framework for a whole new way of thinking about how we need to set up treatments for people.
Yeah, which is mirrored in a wider definition of health and well-being and so on. So services, health services generally are looking at wider aspects of people's lives rather than simply disease, even where disease, as we might define it, clearly exists. Mm-hmm. So this isn't in terms of the challenge or the wider perspective, it's not unique to this particular group. But what makes it especially poignant with heroin users, for instance, is that treatment, certainly in a Scottish context, treatment is very narrowly defined. So largely we're talking about replacement or substitution, principally around methadone, but buprenorphine. And that's seen as enough of a draw to bring people to engage in treatment. And people do engage in treatment in fairly large numbers in terms of the percentage of people who may benefit from that treatment. So that I suppose that's our success. The issue we have is with retaining people in treatment, and also wider than the substitution. What should we provide along beside that, and what actually can be done with people who are, still have significant challenges, both with their substance use and with wider stuff going on in their lives.
So we might think about what you've just said as data. That is, that people in substitution treatment are not retained in treatment. But what is that data indicative of? In our earlier conversation, you were pointing out that many people say that suggests that substitution treatment doesn't work. So going back to what I was saying before about this kind of unitary reductive biological disease model as a presumption, would suggest that a biological treatment would be effective.
Yeah.
In this case, methadone is clearly addressing the biological basis for heroin dependence. But the failure of methadone suggests that there's something more that is not being addressed alongside of the biological medical intervention. And I would suggest that, you know, what happens with all substance dependencies or addictions is that there are a whole host of emotional, psychological, relational, lifestyle, psychosocial circumstances that intersect with the biology of their drug use. And in effect, the person in their environment. And so if we only address one dimension of somebody's relationship to a drug and we don't address the complexity of who that person is and what they're struggling with, which may contribute to why they use drugs, that's a setup for failure. So I would say that the medication might address one of the multiple dimensions of one's problematic relationship to heroin, but we need also to put a comprehensive assessment of who that person is, what their emotional and psychological and, you know, psychosocial needs are, so that we can work collaboratively with people to bring in a whole host of other services that are going to address the complex needs of that person in their life. Psychotherapy, I think, is a key part of that. In many cases, I mean, a majority of cases, we find major histories of trauma. So there frequently needs to be some kind of trauma intervention. People typically have tremendous psychosocial dysfunction in terms of having been marginalized, having difficulties with jobs, with family crises, and so on and so forth. So there's frequently a need to have some kind of family involvement in the treatment to work on, you know, the relationship dysfunction or conflicts that may be factoring into the difficulties they have. So we need to have a much wider lens that we view this complex, unique human with, so that we can put together a comprehensive treatment, or else this one-dimensional treatment is likely to fail with most people.
Yeah, and I suppose the challenge is how you do that, and how you do that with, well, in terms of resources and all that stuff, including time resources, but it's also about professionally, how would you deliver a service that, you know, had that understanding of the complexity of as you say, a human being. So in all that complexity, and also in crisis, so people can come in. I mean, effectively, you're right. What we're doing is we're taking away two significant issues a person has, which is the threat of withdrawal and cravings. But you know, once we've done that, you know, where do you begin? You know, and you know, you can have a toolkit, as it were, but you know, where do you start the job?
I think that one fundamental stumbling block must be social stigma. That stigma about people who use drugs, people who become addicted to drugs, problematic drug users, pervades the culture. I think both in the United States and in most places around the globe. And that social stigma is a kind of semi-conscious or even unconscious justification for offering treatments to people that basically are terribly inadequate, because these patients are being dehumanized by a treatment that doesn't really engage them as whole people, like all of the rest of us. So if we can confront the stigma and we can educate the treatment system to start thinking about people who use drugs and develop problems with drugs as complex humans, Then the next step is we need to think about how do we create relationships, healing therapeutic relationships with drug users that actually engage them, invite them to become meaningfully and actively involved in a treatment relationship. The treatment relationship, we know from all psychotherapy and treatment research, is the most fundamental ingredient to any kind of treatment success. And I think that basic harm reduction principles of starting where people are, on their terms, meeting them with acceptance, compassion, respect, and curiosity, and working to develop a collaborative relationship in which we can actually create a sense of safety for folks to start talking about what their needs are, what they're struggling with, what else is going on around their drug use, and that collaborative alliance becomes a basis for this complex assessment that needs to happen, which can then lead to a really personalized approach to helping people with goal setting in all of those problem areas and putting together comprehensive, individualized treatments.
Yeah, so it's not, what we have is something that can attract people in, as it were. There's very little outreach out, so we're dependent on people coming in through doors. But when people come in through the door, the fundamental thing is then to establish a relationship. And then that relationship is actually the basis for the work. The work is in knowing that person well enough to be able to deal with them as an entire human being rather than a person with one particular problem. And actually, as I say, which might simply be that they suffer withdrawals or they have cravings for a particular substance.
Absolutely, and what I was saying before about language, not only is there are problematic assumptions that are embedded in the way most of us think about addiction. I think there are similar fundamental assumptions that are really problematic embedded in the way that we think about the notion of the addict. Because we presume that the addict is the primary identity of this person and that the addict is incapable of engaging in a meaningful way, that the addict is out of his mind because of his drug use. So we've actually typically approached the so-called addict with this devaluing, dehumanizing stance.
Yes.
So in order to have any hope of establishing a meaningful, collaborative, trusting relationship with this person, we need to shift away from the notion of addict as a defining characteristic to, as you were suggesting, a human being who is complex and unique, who's struggling with a relationship to a drug. And when we can shift into that stance, we have a possibility of actually developing a real relationship with somebody who comes with strengths and with hopes and dreams and motivation to change that we can then partner with. And actually what I've found in my work over many years now is that when we shift into this stance and we actually put out that this is our stance in our literature, in our promotion, in our people who struggle with drugs become very motivated to come for services. It's like when you offer somebody something that doesn't taste good or doesn't really feel good to them, they get kind of turned off. But when you actually make something available that really feels relevant, meaningful, and useful, people tend to become motivated.
So a service can induce aspiration in people, because what we have is an unwritten thing, perhaps for some frontline staff, is around monitoring or assessing people's motivations to change. But actually, what you're saying is that those motivations may well be dictated by what they think, what's an offer from the service itself. And so the way the service behaves and thinks of itself and advertises, as you say, itself, is actually can have an impact on that assessment of people's motivations.
It can have an impact on people's motivation. However you understand addiction, by definition, addiction refers to problematic drug use. So all problematic drug users are suffering. They may not be ready to commit to abstinence. They may not be ready to commit to our goals for them, but they're all struggling in some way. And so if we offer treatments that actually offer to address the things that people struggle with and suffer from and are motivated to begin to make positive change around, people want it. That is, so it's not about helping people become more motivated, it's actually about offering people treatments that address what they are motivated to seek. And you know, most human beings, including most drug users, are motivated to feel better, to have better quality of life, to have better relationships, to have all of the better things that the rest of us want. And so if we shift the focus from this primary focus on abstinence or on the drug use to all of the other things that surround one's use of drugs, and we can engage people in making positive change around all of those things. Interestingly, and again, this goes back to a model of thinking of the drug use as making sense in this broader context. Positive change in other areas of people's lives is going to have a positive impact on their relationship to the drug. For example, if people are struggling with anxiety or with the symptoms of, you know, post-traumatic stress or something else, and they're not motivated to address their drug use or to stop or cut back their drug use, but they are motivated to get some help with their anxiety or their PTSD, and we can engage with them around those symptoms, and they begin to feel better. That contributes to a sense of hope, a sense that I can actually make positive change in my life, and maybe I don't need to turn to the substance, heroin, to manage that anxiety, because now I've got an increasing number of other resources or some relief that I've gotten through this treatment. And that will then support the motivation to make positive change around substance use. You see the model shift.
Yeah. Now, and I think we've also become caught in a focus which actually mirrors the person with the drug problem. The focus has been on substance use and the substances people are using. And that wider thing around people's, you know, emotional states, their anxiety, their depression, is almost a given. So it's not addressed because, well, of course, people who present at this service will present in this way. We did some work recently where, you know, with some older drug users who were, you know, their self-reported mental health around their anxiety and depression levels were huge. And so, you know, it's maybe in addressing that acknowledged problem would be a place to start. But in terms of places to start, where do you start?
Mm-hmm. Again, back to the model shift. The disease model of addiction suggests that, and this is the narrative, you know, since the early part of the 20th century, that you need to address the disease of addiction before you can address all of these other issues, right? That's the primary disorder. And that becomes a stumbling block in addiction treatment to addressing the other issues. But also, and I think it's the same here in Scotland, in mental health treatment. Frequently, people are denied mental health care if they're using drugs, being told you got to deal with your drug use before you can get mental health treatment. So people that are struggling with drug use and mental health issues, which are most of us, are denied care, adequate care on both ends. When we shift to this other psychobiosocial model, thinking of drug use as making sense in the context of a complex person in a social environment, any place, any relevant issue in this complex web of interacting factors that a person is motivated to begin working on becomes the place that we can both engage and begin to create that therapeutic relationship. And we can also borrow from, build on their motivation to make change in that area. And in fact, we can begin to make positive changes or support them in making positive changes, which is going to have a positive impact on their relationship, their problematic relationship to substances. So here's one of the basic harm reduction principles is we start where the person is. This requires a sense of respect and trust that this person has agency that can actually tell us what's most important for them to begin working on. I like to say that, you know, if we can meet people where they are to begin a process of positive change, working in a positive direction, gradually more and more of the difficult factors in their lives can be brought into the treatment, including their problematic drug use, even if it's not the issue that people are beginning to address at the outset.
Yeah, so there's a difference then. I don't know if you're familiar with this terminology, but we've spoken about, and we haven't achieved, regrettably, but we've spoken about having a person-centered approach in treatment. But actually, is it a whole person approach that we require? So we start, it's person-centered in the sense we start where people want to start, or we find people where they are, or whatever. But actually, you know, we acknowledge from the beginning that actually, ideally, what we want to do is address, you know, or engage with the whole person. And what the consequences of that? What I see now that there are more groups, it's easy to engage with people in abstinent recovery because they're forming groups across Scotland. What I see when I encounter people in these groups is people who still have substantial needs, as it were, around their health, their physical health and their mental health. Peter, I'm not a clinician, so I can't make a diagnosis, but people who have palpable problems. And this is regarded as something separate from their substance use. They're now abstinent, and so they don't have a drug problem apart from the challenge of being in abstinent recovery. But in terms of that whole person, they're people who are still suffering human beings, as we all are to some extent. So in that sense, are those people failed by treatment in the sense that somebody who relapses is failed by treatment?
I would say that to the extent that those people have defined success solely based on their abstinence from the drug and have been told that that's really all they need to do in order to maximize, you know, their quality of life, they have been failed. And to the extent that their addictive relationship with drugs had actually been really wrapped up in or reflective of some complex emotional, psychological relationship challenges that have not been addressed, that's going to be a huge setup for, quote, relapse.
Yeah.
And I think frequently we need to consider that the drug use and the urge to use the drug is like the leading edge of this complex, often unconscious or dissociated web of feelings and experiences related to trauma, related to loss, related to, you know, early trauma or trauma related to being a drug user. And that to the extent that it's been dissociated, that is kept out of awareness as a way to cope with it, simply stopping the behavior without addressing all of what was driving it keeps somebody in a very precarious form of recovery, which in the recovery community, that's even been almost acknowledged in statements like, you know, when I'm not using, my disease is in the parking lot doing push-ups. Or, you know, my disease is always right over my left shoulder, you know, ready to pounce. Well, addressing the substance use is one very important and positive step, no doubt. It's better to be abstinent from injecting heroin than to be injecting heroin, given all of the risks associated with illicit heroin. However, if you haven't really taken your so-called disease off the shelf and kind of looked into it to discover, you know, what was driving it? What were those feelings, those needs, those motivations, those parts of me that, you know, haven't been addressed otherwise? It's a recipe for disaster. So treatment, whether it's substitution treatment or abstinence-based treatment or moderation-based treatment, I think needs to include some attention to these complexities. And as we can help people discover what are the forces, the motivations that, you know, have been driving that urge to use, we can name them, we can integrate them, we can make sense of them, and we can find more effective, healthy ways of addressing or expressing them in ways that are more consistent with our other values of health, of relationship, of, you know, all of the other things that are important to us.
And in terms of the, I don't know if you have this term, but in terms of the nitty-gritty, what is it we're doing with people? What is it you're advocating in terms of that therapy? What does it look like? Is it motivational interviewing? Is it CBT? You know, what hat do you wear? Or your professional approach? Or
so I've been in the field for 35 years trying to make sense of drug users and the struggles they have and how to come up with a comprehensive framework for helping. And what I've come to is what I call integrative harm reduction psychotherapy, or substance use treatment. And what I mean by that is that I think the harm reduction principles are a kind of frame. They frame our relationships, the way that we set up helping relationships. The principles I have in mind are that we accept any positive change as a measure of success and an acceptable goal. So we shift from abstinence only to whatever positive change the person is ready, willing, and able to begin to work on. We accept that. We then start where that person is. We embrace small incremental positive steps, and we work collaboratively. So this is the kind of the therapeutic frame. Now, moving from that more complex model of seeing the problem drug use in the context of a complex human in a social environment, I think we then need to bring together a wide range of therapeutic modalities and interventions to bear in our collaborative discussions with patients so that we can make use of motivational interviewing, CBT, cognitive behavioral interventions, even psychodynamic, psychoanalytic formulations that attempt to discover meaning that gets reflected. Mindfulness is a tremendously powerful strategy for supporting people in developing a greater capacity to sit still, to do the work of exploring cognitions, behavior, and meaning. So, and medications and medical interventions. So we've got to, I think, as clinicians, be equipped with a wide range of different therapeutic tools and strategies that we can offer to the individual patient and collaboratively negotiate a treatment that's going to be uniquely tailored to that person. So we're moving from one size fits all, you're an addict, we know what you need to do and you need to do it our way, authoritarian, prescriptive, to a whole different framework which is collaborative, respectful, and in which we support people in discovering what's true for them, what goals and approach to change best suit them, and then we can work collaboratively to create the treatment that will best serve each patient that we work with.
That approach is based on it has to be based on an expectation from the patient themselves. So how do you open up that conversation with people who's not only their engagement with treatment services, but their engagement with the state and with services generally has been that authoritarian thing. So people are basically engaged with services probably because they've done something wrong, and there'll be some threat involved with that. And you know, those relationships with services may well go back to somebody's childhood. That might have been their relationship with school. It was somewhere that they went to be punished and then eventually opted out of. They're then involved with the criminal justice system and the police. And then when they come to engage with services, it's actually not very different. And I don't mean that in a disrespectful way to individuals working within treatment services, but there will be awareness amongst that patient group or whatever that you can get treatment, but it's conditional, and it's conditional on you behaving in a certain kind of a way, which isn't the way I engage with services around my health, or health services are generally configured.
That's a huge problem. We might consider that hypothetical person that you just described, has experienced a history of trauma at the hands of the authorities, possibly even what I've come to call treatment trauma. If I set up a treatment so that the only way you can get my help is that you need to submit to my authority, and you need to do it my way, I'm really asking you to somehow disconnect from your own needs and submit to me. That is inherently traumatizing for many people. It reflects or replays kind of earlier traumatic experiences in which people were not valued, they were not respected, their personhood wasn't seen. So many of these patients have experienced many experiences like that. So they, and also particularly if they're mandated, the mandate itself and the threat of losing certain other benefits or entitlements if they don't submit to treatment is a whole setup for a kind of re-traumatization. So it seems to me that this is one of the major stumbling blocks that treatment providers have to address, you know, the question of how do you create a sense of safety? How do you help that person who's expecting to be re-traumatized, to help them come to open up and believe that you might actually be a trustworthy clinician who is really on their side? So I think that that's often a clinical issue or an issue that needs to be addressed with people right up front at the beginning. And the clinician needs to be really clear that the clinician is on the side of the patient and not on the side of the mandate. I mean, mandate is reality. So, you know, part of a harm reduction approach is that we want to help people more effectively come to terms with how they engage with reality, whether it's the reality of their problematic drug use or the reality of state, you know, mandates. But that doesn't mean that we can't create this kind of person-centered collaborative therapeutic relationship even in that context. But we have to somehow find a way to convince that individual that we're trustworthy and worthy of them, you know, bringing themselves more fully into the work with us. Now, I thought you were going to ask another question about...
Ask your own question.
No, I mean, that is, this kind of work that we're talking about requires a major commitment on the part of the state, the funders, the community. A commitment that must be based on a recognition that people that are suffering and struggling with problematic drug use need a lot of services and a lot of support. And so, and I think it's not just, this issue is not just present in Scotland, it's a universal issue. Many people wonder, why should the rest of society invest all of this in offering this kind of complex, comprehensive care to these patients, to these people, these drug users? And it seems to me, on the one hand, it is a values question. Do we as society extend the same notions of human rights and human dignity and the right to adequate health care to drug users as we do to the rest? There's also, I think, a self-serving or a pragmatic principle, which is, you know, is there more suffering and more cost to those individuals, their families, and the broader community by denying this kind of service compared to offering it? And even at earlier and earlier points in the trajectory of people's drug use careers, I think that there are good arguments to be made that we should be, part of our drug policy changes, reforms, need to include a commitment on the part of, you know, the government and the broader society to offer comprehensive care to people that struggle with drug use, because I think everybody benefits from it.
Yeah, although that argument is harder to make, or hardest to make, when drug use itself is stigmatized to an extent that people who use drugs are stigmatized in all their wholeness of their humanity. It's not just their drug use is condemned, but it's them as people. And that stigma extends to them in absent recovery to an extent as well, and also extends to the services that work with them. So where you have specialist services, those services themselves and the people working within them carry some stigma, which I know, even on a most fundamental basis, if you get into a taxi and someone asks you what your job is, working with drug users doesn't necessarily make you popular. So, you know, to the taxpayer, the wider community, whatever, hold that stigma for that group. And in terms of reducing that stigma, have you been able to have any insight around how that might be done? I mean, I suspect some of this is cultural. The specificities of it, is if that's a word, are cultural. But what do you think yourself?
Well, I think part of the reason that I talk in terms of a paradigm shift, in terms of a new model, the need for us to adopt and consider a new model, what I call psychobiosocial process model, is that we need to offer people a different way of connecting the dots. That is, the disease concept and our older concepts about addicts and addiction are one model that is kind of like a lens that people are viewing these people through. And when you look through a certain lens, you see what the lens dictates. As you know, we've been suggesting, that lens, that old lens, is not really supported by data. And people can't see things differently unless they are educated about a new lens, a new paradigm. So I think a big and important part of changing and challenging this stigmatizing presumption is offering people a new way to think about people who use drugs that rehumanizes them, that recontextualizes their drug use. So at least some people will see the new paradigm and feel on some level, of course it makes sense that, you know, our brothers and sisters and fathers and mothers and neighbors who get into trouble with drugs are people just like us. And in fact, how many Scots actually have family members who have gotten into trouble with drugs and had terribly catastrophic outcomes? So I think I don't know about Scotland, but I do know that in the United States there's a growing movement of families and community members who have suffered through their own addictions or addictions and losses of their loved ones, who are beginning to recognize that this old model of inadequate treatment and failed, you know, criminalization has been a catastrophic failure, and people are starting to look around for a new way to think about it and to intervene, and we need to supply this new vision.
Well, thank you, Andrew. I think you've supplied some of that vision in this short interview, so thanks very much.
It's been my pleasure. Thank you.